Chapter 9, Routine Venipuncture. The requisition forms must have, at a minimum, the patient demographics, including their full name, date of birth, their sex, so male or female, and their race. For inpatients, hospital ID number needs to be on there as well, the room and bed number, too. Name or code of physician making the request, the tests that are requested, and then the test status. So short turnaround time, is it stat, is it timed, or is it fasting? The requisition form is going to allow us to identify the patient correctly, and it also can help provide, other helpful information as well. It's going to tell us what the specimen should be collected is. It allows us to gather necessary equipment for the collection before we encounter that patient. Steps of a routine venipuncture, we need to always, no matter what we're doing, greet and identify the patient. Position and prepare the patient. We want them to be comfortable. Perform hand hygiene and put on gloves. Apply the tourniquet. Select the site appropriate. Palpate the vein. Clean the site. Assemble our equipment. Reapply that tourniquet and examine the needle. I always like to clean the site after I put the tourniquet back on, just because if you clean it prior to that and something touches and you don't notice it, or something does and you have to clean again. Then we would perform the venipuncture, fill the first tube, and advance and change the tubes, remove the tourniquet, prepare for that needle removal, withdraw the needle. We're going to dispose of the entire collection, so the needle collection system, into the sharps container. Label our tubes before we leave the patient's side. Attend to the patient, so make sure their collate's in reach with those types of things, and then deliver the specimen down to the lab. With inpatient requisitions, examine them to make sure it has the necessary information. Again, full name, date of birth, the ordering physician, and the patient location. Make sure we check for duplicates. Prioritize the requisition. So, do we have stat tests? Do we have time collections, routine, those types of things? We need to prioritize. And then collect all the equipment we will need for the collection, and then we can go perform it. Advanced beneficiary, notice of non-coverage. Sometimes patients covered by Medicare may request a service that's not eligible for reimbursement. Patients must sign an advanced beneficiary notice of non-coverage, so they're acknowledging that it is not covered by their insurance, that they will be required to pay for whatever that cost is. It shows that the patient understands the service may not be reimbursed to them, and again, must be presented to patient far enough in advance prior to that service. As we've talked about before, patient identification is very important. Correctly identifying our patient is the most important step in the phlebotomy procedure. Even if no harm comes to the patient, drawing blood from the wrong patient may result in dismissal of the phlebotomist and the potential for a lawsuit. So we need to be very careful on that. All inpatients should be wearing an ID band issued by the hospital. So that's where we need to verify with the requisition form, their ID band, and having the patient state their full name and date of birth. We need to make sure we greet and identify our patients as well. Knock gently before entering the room. Don't just barge in. Say that the physicians ordered the test without discussing really any of the specifics. Again, we're going to ask the patient to state his or her full name and full date of birth. Check the requisition or the labels against this patient, so the provided information in the patient's ID band, and then ask the patient if he or she has had their blood drawn before. With positioning and preparing the patient, we never want to draw blood from a patient sitting on a high stool or standing. Even if they insist, they need to be sitting down. Outpatients can be seated in a special chair with the arm support. For our inpatient, we may lower the bed rail for better access, but we need to remember to raise it back up again after the procedure, because again, we don't want the patient to fall out from us not putting that rail back up. We need to support the arm for venipuncture under the elbow with a pillow, Ask the patient to remove foreign objects from their mouth. And we want to make sure we explain the procedure and get verbal consent from the patient. Sometimes we do things in healthcare that we're like, everybody knows what this is, we don't need to explain it. We still need to explain it to the patient. We still need to get their verbal consent from them. Explain to the patient that he or she will feel a small poke or pinch and should remain still throughout the collection. Never lie to a patient, especially children, if they ask if it's going to hurt. We need to be honest with them because if we lie and tell them that it doesn't and then it does, they're not going to trust us. They may not trust other healthcare workers as well, and we don't want that to happen. Hand hygiene, gloves, and applying the tourniquet. So perform hand hygiene and put on gloves. Okay, that should be our first thing. Apply the tourniquet. We're going to go about 3 to 4 inches above the puncture site, and we do not want to place over an open sore. To tie the tourniquet, hold one free end of the tourniquet close to the patient's arm, crossing it over the first end on top of the arm, forming an X. Then we're going to pull the lower side of the tourniquet taut and grasp the X between the thumb and the forefinger of one hand. With the other hand, tuck in the upper strip close to the X by sliding it under the other side from above. Both free ends should be away from the puncture site. And again, I've showed you a couple techniques of tying tourniquets. You don't necessarily have to use this one. We just need to make sure that the tourniquet is tight enough where it's not too tight and that both those free ends are facing away from that puncture area. The tourniquet, again, should not be on the arm for longer than a minute, so we need to kind of pay attention to that timing. Improper tourniquet application can cause hemoconcentration, which is an increase in the ratio of formed elements to plasma. Hemolysis, so that destruction of those red blood cells, which can alter test results. And petechia, which is small red spots on the skin caused by a tourniquet that is too tight. We need to make sure we select the best site. The median cubital vein is the first choice. Okay, the cephalic vein is the second choice. The basilic vein is the third choice. And again, that basilic vein would be the absolute last choice if nothing else is good, because again, that falls very close to the brachial artery and nerves that are running along that side. We want to make sure we palpate the vein. We're gently pushing up and down with the index finger. This is really determining that depth, the width, and the direction of the vein. Veins feel spongy, bouncy, and firm. Okay, arteries pulsate. Tendons are going to feel rigid and don't spring back. Okay, so we want that spongy, bouncy, but firm vein feeling. Cleansing the site, assembling our equipment, and so on. Using a 70% isopropyl alcohol or other antiseptic, we're going to clean the area in concentric circles. Okay, spiraling. Allow the site to air dry for a maximum bacteriostatic action. We would reapply the tourniquet if it was removed during that cleansing process. Uncap the needle and examine it for any defects. Very, very important step. We would want to anchor the vein by gently pulling the skin taut with the thumb of the non-dominant hand. Hold the needle assembly with your dominant hand with the tube inserted up to the line on the adapter. We want to make sure we insert the needle bevel up in one smooth, quick motion. You will feel a slight give when the needle enters that vein, and hold the needle assembly very steady. Again, like I showed you, to keep that nice, steady, in control grip there. We're going to fill the first tube, push in the tube, okay, with the hand that anchored the vein. Use your thumb to push the tube in. Be sure to pull back with your fingers on the phalanges of the adapter to prevent pushing the needle in farther. Remove the tube when blood stops flowing into it. Gently pull the tube to remove it. Again, it helps to push against the flange on the end of the holder as you do so. The tourniquet may be removed after blood begins flowing into the first tube. The tourniquet must be removed before the needle is removed from the vein. Pull on the free short end to release it from the patient's arm. Some phlebotomists, you will see, as soon as they get that blood flow in that first tube, they pull that tourniquet. Others leave it on to the very last tube. When the last tube is almost full, then they take that tourniquet off. Again, we need to pay attention to our time limit, again, because we don't want to leave that tourniquet on longer than a minute. So we should be paying attention to that, but we don't necessarily always take it off as soon as we start that collection. When preparing for needle removal, you need to remove the last tube before removing that needle. This is going to prevent blood from dripping out of the needle. We'll withdraw the needle, pull the needle assembly straight out from the patient's arm, and activate that safety feature immediately. Apply a gauze square folded in quarters to that puncture site, and I usually have the patient put pressure on that while I'm, cleaning up. The entire collection set needs to be disposed of. So use a disposal method and container designed for the type of needle you're using. Again, we're going to be using those red sharps containers. We aren't going to disassemble it or anything. We're going to throw the whole thing in, okay? We're going to label the tubes. So label each tube at the patient's bedside or in the drawing room in the presence of an outpatient. Use a ballpoint pen or a permanent marker, and we never want to label a tube before collection, because again, maybe that tube gets pushed aside and we end up not drawing it on that patient we labeled it for, don't recognize it, now that's mislabeled. So we never want to label before collection. Attend to the patient. Check that puncture site to be sure the bleeding has stopped. Some patients' veins don't close automatically, and so we do have a little bit more bleeding. So I always have them hold that pressure as I'm cleaning up, and before I put tape on that, I'm going to lift that up a little bit, peek, and make sure that vein has stopped bleeding. Dispose of all contaminated materials in a biohazard container if your facility says. Most of that stuff, other than the needle stuff, can go in the regular trash. Place all of your specimens in either bags or tube holders, and then remove your gloves and wash your hands, and thank the patient. Delivering the specimen, we're going to follow the laboratory's policy about recording your work in the computer, logbook, or other tracking system. Log the specimen arrival time in that logbook. And again, this is going to depend on your facility that you work for. Routine venipuncture with a syringe. We're going to follow steps 1 through 8 and 10 of procedure 9. Prepare syringe and perform venipuncture. We're going to fill the syringe, so we're going to pull back the plunger evenly, gently, and slowly to withdraw the blood. We want to make sure to firmly brace the hand holding that barrel against the patient's arm so that only the plunger moves. Remove the tourniquet. Okay, we want to prevent hematomas. Withdraw the needle and transfer the blood to the evacuated tubes. Follow step 16 of procedure 9.1. We're going to activate that safety device. Transferring the blood to evacuated tubes is done in the same order as if the evacuated tube system were used. So same draw order. Place tubes in the tube holder then. Dispose of the syringe and the transfer device together in the appropriate container. Complete the procedure and finish as in steps 18 through 20 of that procedure 9.1. With the winged infusion set or the butterfly, we're going to assemble our equipment, position the patient's hand, and apply the tourniquet. Remember, tourniquet is going on the wrist for the hand draws, not clear up above the AC. Insert the needle, collect our specimen, finish up collection, again, attend to the patient, and then dispose of that winged infusion set in the sharps container. Any questions on Chapter 9? If you have any, please jot them down. Send them to me in email. I will either answer them in email or I will answer them for you next week.